So this is Tiffany Watts, January 27th, 2020. This is part 2. My other video got cut off, so I'm uploading in part 1 and 2s. So this one is the case about the newborn metabolic disorder. Given the options and patient history, I believe the best diagnostic tool in order to compare a urea cycle disorder to a beta oxidation disorder would be ordering a plasma glutamine level. So as we've learned in class, and the research that I researched, glutamine is an amino acid which is non-essential and non-toxic in the body, but it is important in the body because it transports ammonia. So in patients with urea cycle disorders, you typically see an increase in the ammonia levels and the plasma glutamine levels. So plasma glutamine is an important diagnostic factor in the determination and diagnosis of a patient with a urea cycle disorder, as the main purpose of this is to confirm or rule out hyperammonemia, which is elevated ammonia levels. Plasma ammonia levels are routinely elevated in these patients, and a high level of glutamine can oftentimes serve as that validation that a patient is suffering with the hyperammonia. So in patients with beta oxidation deficiency, glutamine levels should typically remain unaffected, which also serves as a diagnostic factor in determining a UCD, which is a urea cycle disorder, or beta oxidation disorder. So to determine if a patient has beta oxidation disorder, you need to understand what that is. So BOD involves a deficiency in the enzymes required for lipid metabolism, which will result in an increase in serum fatty acid levels as a result of being unable to properly break down these lipids. So given this patient's labs and HPI, this is consistent with an OTC deficiency, which is referred to as the ornithine transcarbamylase deficiency. This is a type of urea cycle disorder that, as the name suggests, is a result of the OTC enzyme being injured or misplaced. So as a result of this deficiency, the urea cycle cannot move forward as normal, which will in turn cause an accumulation of plasma nitrogen, which is in the active form of ammonia. So some clinical symptoms include, like mentioned above, the hyperammonemia, lethargy, and apnea-like features, all which this patient is presenting with. The symptom of hyperammonemia is also consistent with the patient's ammonia level rising from 314 to 600 in such a short span of time. So as a result of this OTC deficiency, the carbamylyl phosphate accumulates in the mitochondria that leaks into the cytoplasm. So from here, this is redirected into pyrimidine synthesis, which will result in an increased level of the orotic acid in the urine. So these elevated levels of orotic acid in the urine are also key in determining an OTC deficiency from a similar CPS1 deficiency. So given the above, it's likely that the deficient enzyme in this case will be OTC, and the least likely to be impaired is that CPS1. The increase in this orotic acid in the urine is also consistent with the patient's orotic acid being 470. But you also see the normal citrulline levels. This is in part due to the mechanism of action of both of those. So the high levels of the urinary orotic acid is consistent with an increase in the production of the carbamyl phosphate, but is not using the accumulation of OTC to synthesize citrulline, which is why we see that normal level of citrulline in this patient. References are listed below, 1 through 6, and numbered appropriately. Thank you very much.